Welcome to In Session, the North Carolina Healthcare Association's podcast where we dive deep into critical issues impacting hospitals, patients, and the overall health of our communities. Whether you're a legislator, policy advisor, or community leader, this series is designed to keep you informed about the challenges and opportunities in healthcare today. Here's your host, Nicholle Karim, Vice President of Policy Development at NCHA.
It's common discussion to talk about how a business is run or how branches of government work. But have you ever wondered what it takes to run a hospital? Our guest today does, and he's going to share his perspective on the inner workings of leading a health system, specifically a 9-hospital rural health system, ECU Health. Brian Floyd started his career as a nurse in the post-op cardiac surgery unit at the same hospital where he now serves as the Chief Operating Officer of the ECU Health enterprise. His passion for improving healthcare for Eastern North Carolina is undeniable. Brian serves on several national and state health boards, including here at NCHA. Welcome, Brian.
Thank you, Nicholle, and thank you for having me today. It's such a privilege to participate with NCHA on podcasts and places like this where we can educate, inform, and bring everybody into this work. I've had a rewarding career so far. 30 years I've been in healthcare, but what makes it so rewarding is, rarely do you get to do something that is so meaningful and so transformational for communities as healthcare is. Organizations like NCHA are essential in partnership with us because it allows us to have advocacy for policies, and it helps us convene knowledge together across hospitals. So I'm very appreciative to be with you today.
Well, Brian, I'd imagine running a hospital requires a delicate balance of priorities, not only to keep the day-to-day operations going, but staying on track to reach strategic goals and continuing to serve patients and communities effectively. Plus, with ECU Health serving rural communities, there might be different challenges compared with urban communities. So I'd love to learn more about your approach to the priorities and how they all fit together.
When we think about healthcare and the healthcare industry, there are many stories nationally about this. Obviously, healthcare is a statewide industry as well, but it's really delivered in local communities. And so you have to put the context of healthcare in focus when thinking about how all this works. Here at ECU Health, we are part of a rural community, and urban and rural healthcare is quite different. Certainly, the context of rural healthcare is different because you have higher geographic distances to travel. There are less densities of the population. The socioeconomics tend to be very different in rural communities. And for instance, at ECU Health, every place we're operating is a Tier 1 economic community. That leads to worse social determinants of health and higher instances of healthcare disparities and ultimately higher levels of utilization. What I love about ECU Health is that it has committed its mission to improve the health and well-being of this community in this region across 29 counties. That's why today there's a 1,000-bed hospital sitting in a town of only 60,000 people. Anchored as the organization's anchor with 8 hospitals spread around the region that are community-based hospitals and more than 130 clinics that are spread around our region. This organization is partnered with Brody School of Medicine because along with that mission, we want to create an academic healthcare system that can train and develop the workforce for the future. And so Brody School of Medicine is the state's highest volume of rural healthcare family medicine physicians who are practicing in rural communities all across the state. So the organization itself, in the context of rural healthcare, has different challenges to overcome. And it's a privilege for us to do this work. And it's why I love being at ECU Health.
Brian, and so interesting to hear you talk about these other factors that drive health, like personal finances, transportation, other things that you have to consider as a healthcare leader, especially as our state is having so many conversations about whole person health. So that sounds like a lot to balance.
Hospital care is expensive in any context. Running hospitals is very expensive. And the reality is the cost of doing business can be the same. We pay the same amount for medications here at ECU Health as someone would in an urban, more prosperous environment. The cost of labor tends to be at least as high, if not higher. But the revenue sources are much lower because of the socioeconomics of the community. So in many cases, we're more challenged to create a system that has high efficiencies and consumes less resource to deliver a very high level of care to the patients we serve. And it's what makes it challenging, but it's also what makes it so rewarding.
Well, given that, Brian, the challenges you all have, I'm sure you have some items that are on top of mind that we could drive innovation and change on. So I'm curious, what are some of those policy areas as a not only a hospital leader, but a rural healthcare leader that you see as some ways that we can improve your ability to serve patients?
Well, the unique challenges we're talking about, whether they are the economic challenges, whether they are workforce challenges, are all part of the story that we are always trying to find solutions for. And obviously, there's a lot that we do in medicine and delivering patient care, and a lot we do socially to try to help improve the conditions in which patients are caring for themselves and preventing diseases and so forth. But the context is determined not just by what we do, it's determined by economic policies created at the federal level, at the state level. And it's determined by the resources around us to help train and develop a pipeline of workforce for the future. When I think of what we're doing, we are certainly delivering care at the highest levels, at quaternary levels, to this community. And that is transformational for their health care. But perhaps more importantly, we're also educating and changing the culture and education levels and health literacy across this region where there are major gaps in understanding. And finally, perhaps the most significant thing is that a healthcare system operating in a tier 1 community or tier 1 region like this is also usually the largest economic stimulus to that region. And when I look at what's making the difference in healthcare outcomes, and in the prevention of disease here at Eastern North Carolina, the vitality created by the work we're doing is part of the story of improving the health and well-being of the community. For instance, we are trying to use our apparatus, the healthcare apparatus, where we have partnerships with 5 and 6 colleges to train and develop people from Eastern North Carolina, from these tier 1 communities, sponsor them into college, train them, and get them to work with us here in serving their friends and neighbors back home, because it not only provides for the workforce and overcomes the shortages in the pipelines, but it also sponsors those communities they come from. It helps people give back and help create economies that support their families and help them come out of poverty situations. And so when you look at being transformational, the industry has to provide for the infrastructure differently in rural communities than it does in urban settings. And so policies are really important to that. One reason why NCHA is so powerful to ECU Health is we can't do this without economic policies that help us in this region because of the revenue gaps that exist. That's why we're so passionate about things like Medicaid expansion, Medicare, 340B programs, and the funding of graduate medical education slots that help us train the next generation of workforce. Those are just some of the policies that we know are essential for our ability to meet the mission here in the East. And NCHA is a powerful group to help us achieve that. When considering the importance of rural healthcare support by governmental resources is to go back in time and remember that many of these community hospitals that are spread around counties in our state and the nation, they stem from the Hill-Burton Act back in the late 50s and 60s when these were built. In many ways, those hospitals would have never been built. They weren't going to be solvent on their own. And so capitalizing those hospitals was a partnership between the state, the local community, and the federal government to establish those hospitals. What most people don't think about is, particularly in rural communities, those facilities are still the facilities in motion today. And so as we look at, here we are 60 years later in many cases, these facilities are now outdated. They're small. They're in many cases inadequate, but they're still operating in those tier 1 economic communities where recapitalizing the facility is really hard to do. And so as we look to the future, how the government helps support rural communities themselves, establish funds that can help recapitalize those hospitals, is a unique issue to rural communities in my mind.
Brian, that history about the Hill-Burton Act and how rural hospitals came to be is such important history. And I can't help but think about certificate of need and the purpose of certificate of need. And so I'm curious, from your perspective as a rural hospital leader, how does certificate of need fit into making sure healthcare is accessible in rural communities?
It's an interesting dynamic when you consider that most 2/3 of the state live in rural communities. Many of them in these communities where these small, rural, Hill-Burton type hospitals are funded. The CON, the Certificate of Need law, protects the dangers that come from competitive threats to those hospitals. Those hospitals are going to take care of every patient that comes. And those patients many times do not have the ability to pay. And so you have a higher negative payer mix. And what the CON allows us to do is maximize the internal revenue of that hospital so that we can protect it enough to have reinvestment funds to keep that hospital going forward, reinvest in technology, and keep modernizing it. The challenge to the CON is that if that's not in place, you have competitive threats to that. People will pull out not all the services from the hospital, but those that tend to be more profitable. And while that may lower the price of care for one patient and seem like the right thing to do, it ultimately lowers the value created by the hospital, and you then start to see deterioration of the whole infrastructure. And because we really need all those parts of revenues to help support a hospital that is in the condition in which it needs to retain all that revenue for its growth and its ability to modernize its technology.
So that's where we hear about hospitals or health systems who have to de-invest from health services like behavioral health or labor and delivery or emergency care. Are those the type of impacts you're talking about, Brian?
Yes, indeed. I mean, when, like any other business, the hospital does have to break even. It has to be able to be solvent to pay its bills. And so we can deliver the service to the level of our financial ability to do so in a community. And if you pick apart the revenues that help support a hospital, ultimately, you render that hospital less capable to invest in things that are very costly or things that do not return funds back to the hospital, and certainly limit its ability to make big capital investments when it needs to borrow money to do so. And so, when you think of CON protections, we think rural or urban environments where there's competition, and people see that as a good thing to help sponsor competitive value creation. But particularly in these rural markets, it can be devastating to a hospital when it's barely breaking even to begin with.
Patient care and improving the health and well-being of communities tops the list of goals for hospital leaders serving in rural communities. And you've touched on that a lot during this conversation. What are some of the tactics you've implemented across ECU Health to create better outcomes to support the ultimate goal of better patient care?
Well, in our health system, there are so many things that we are proud of among the 15,000 people who work with us here at ECU Health. Obviously, developing and training the workforce for the future is a key part of the strategy of improving the health and well-being of Eastern North Carolina. The reason we say our vision is to be the national model of rural health care is because we have the educational platform to do research in population health outcomes, reach our communities as a fully integrated system of care, and at the same time train and develop the workforce for the future. And so from a sustainability platform, that's been a huge priority in helping improve the well-being of communities, as I mentioned, the vitality of those communities, the economics created, as well as healthcare. And at the core of it all, at the highest levels of healthcare, we have seen year-over-year improvement in each of our quality and patient safety indicators and our experience indicators, because our teams are relentlessly focused on how do you create greater value, greater quality, week to week, day by day. And so one of the things I'm just so proud of is the cultural improvements in ECU Health that have driven not only how we deliver care with higher levels of safety, better outcomes year over year, but a sustainability that's coming from the retention of people who have joined us. Last year, we hired over 4,000 people to join ECU Health. We had over 200 providers join us last year, just in 1 year. And bringing those people into this work and having them help us pursue higher levels of care is showing up in the indicators of our performance, whether they're quality, experience, financial, or workforce development. So our strategy is to keep a culture of continuous improvement in motion, and we are certainly enjoying some of the benefits of that today. We're also partnering with others. Through the state, we're able to expand Brody School of Medicine's class size. That will produce more primary care physicians, not just here in Eastern North Carolina, but for all of North Carolina. I saw statistics recently that 1 in 5 of all of North Carolina's primary care physicians are Brody graduates right here at ECU Health. And 5 years after graduating, 60% of the family medicine students are still practicing in a rural community of North Carolina 5 years later. Those are tremendous outcomes that demonstrate our focus on rural healthcare production. And that comes from a culture that is growing in its ability to create an attractive place for people to work, an attractive field for people to have a fulfillment of their own career aspirations, in addition to the quality and patient safety that we're rendering. We're in the process right now of completing construction of a new behavioral health hospital that will serve the Eastern North Carolina, 140 beds dedicated to not only adults, but child and adolescent care in the East. So despite the pandemic, the work that we are doing today is about moving forward and meeting the needs of the communities for the future.
Well, Brian, it's clear that you and ECU Health are doing so much and spinning so many plates and keeping patients at the center. So I really appreciate your time today and this really thoughtful discussion. And the work you do is honorable. And we're really glad we get to work with you as a member and also sit down and learn more about your perspective of running a rural hospital system.
Thank you, Nicholle. It's a privilege to do this work. I'm so happy to help NCHA and be part of the story of how we all come together to create an industry that is so important to the communities we're all serving here across the state.
Thanks for listening.